Hello, my name is Carrie Ortega, Health IT Project Manager, and welcome to the Iowa Medicaid Electronic Health Record Incentive Program overview for the incentive year 2016. This presentation will include helpful attestation information for program year 2016. Today's presentation will focus mainly on eligible professionals and the Iowa Medicaid Attestation System for 2016. We'll begin by going through a few attestation reminders, then move into requirements for 2016 attestations. We'll then take a look at the alternative attestation method for those subject to the Medicare payment penalty, and finish up with changes for the 2017 program year. If you are an eligible hospital and have questions regarding your attestation, please contact us. There are several tools for eligible hospitals posted on the DHS Health IT Electronic Health Record Incentive webpage. Dates to remember: March 13, 2017 is when the CMS Medicare attestation website will be closing down for the 2016 incentive year. March 31, 2017 at 11:59 p.m., the Iowa Medicaid EHR Incentive Program Year 2016 attestation deadline occurs. Please make sure that you have submitted your attestation application for the 2016 program year by this deadline. April 1, 2017, Iowa Medicaid EHR Incentive Program Year will begin accepting attestations for the 2017 program year. That's because at least 90 days will have had to have passed in 2017 before you can actually report for the meaningful use 90-day reporting period. Other dates to remember are listed on the CMS Electronic Health Record Incentive Program website, and by clicking this link you will be taken there. The last chance to initiate participation in the Medicaid EHR Incentive Program is the 2016 incentive year. There are many tools and links posted to the DHS HIT EHR webpage. As a reminder, the patient volume calculation always comes from the previous calendar year to the incentive year. If a provider does not have patient volume from calendar year 2015, they may not be eligible. Stay tuned. We're going to spend some time in the upcoming slides which focus specifically on the patient volume calculation. Next, we're going to take a look at some PIP system attestation tips, and within the system, some screenshots. Here is a screenshot from the PIP system after a provider has logged in. On the home link, you will find the dashboard. The dashboard consists of correspondence, payment history, and current status of the current application. I've highlighted those sections here. Under the correspondence, it will show the date of the correspondence from the IME PIP system, any emails with hyperlinks. You are now actually able to view the email sent within the PIP system, but for only those that have that hyperlink. A reminder that all correspondence is sent to the email address provided on the CMS registration and attestation site. Current status could be pending as shown here, which means the application has not been submitted to the IME for review. The most common statuses are eligible professional application pending, review, review secondary, payment complete, and application denied. If you inquire about the status of your application, you will be referred to this screen titled Dashboard, so you can check the status of your application. Attestations submitted to Iowa Medicaid EHR Incentive Program go through 2 complete and separate reviews to ensure all program criteria are met prior to payment being issued. The queues are worked on a first-in, first-out basis. If all criteria are found to be met, then the attestation is processed for payment. If during the review the attestation is found to have issues or incomplete information, then the attestation is returned to the provider to make corrections and resubmit the attestation. When the attestation comes back into the IME for review, because you've resubmitted it, the attestation goes to the bottom of our queue, and again the attestation is worked on a first-in, first-out basis, and again goes through the 2 complete and separate reviews to ensure all program criteria are met prior to the payment being issued. We talked about the correspondence and how anything that has a hyperlink, you'd be able to see that email if you clicked on it. Here's an example of an email that will pop up if you click on the correspondence email link. Here is the PIP screen after an eligible professional clicks on the Apply for Incentive Attest link. All of the current case information that you see here comes from the CMS Registration and Attestation System and shares over to the Iowa Medicaid system. You need to verify the current case information is correct. If you need to make any changes, you will need to go back to the CMS Registration and Attestation System to make those updates. Then wait for an overnight and the changes will appear here in the Medicaid Attestation System. Ensure you go all the way through the CMS Registration and Attestation System process for making the updates. Sometimes the update process is not completed at the CMS Registration and Attestation site, and then the information does not share over to the state. There are user guides available on the CMS EHR Incentive Program for those that need some additional assistance on what to do or how to do something for the CMS Registration and Attestation site. All communications and correspondence will go to the email address listed under Email in the current case box. The Payee NPI listed in the current case section is where the EHR incentive payment will be paid. The alternate email comes from the Provider Questions screen. You have the option of providing an alternate email address, which will now share up to the current case information. This is the only field in the current case information box which does not come from the CMS Registration and Attestation System. Now let's take a look at some of the items which are often reasons for a returned attestation under some of the attest links that you see here, such as Provider Questions, EHR Questions, and Patient Volume Questions. The first question on the Provider Questions screen is, are you currently enrolled to bill as an Iowa Medicaid provider? Yes or no? This question should be answered how you have enrolled with Medicaid. Part of the prepayment audit process is to verify a provider's enrollment status. This question must be answered accordingly. So for instance, if you're enrolled as a referring prescribing provider, answer this question no. Are you a pediatrician also appears on the Provider Questions screen. And for the purposes of the Iowa Medicaid EHR Incentive Program, the definition of pediatrician is a physician who is board certified in pediatrics by the American Board of Pediatrics or the American Osteopathic Board of Pediatrics. Supporting documentation should be attached to the Provider Questions screen. And keep this in mind as you are attesting, if you are attesting for patient volume as a group definition. So those groups attesting with pediatricians should be aware that all EPs in the group must meet the definition of pediatrician for purposes of the EHR Incentive Program if they attest below the 30% patient volume threshold. So there's the 20% or greater Medicaid patient volume, but below the 30% patient volume threshold, then your group would have to be all pediatricians. But for those who attest as a mixed group consisting of EPs who do and do not meet the definition of pediatrician, then that group must meet the 30% patient volume threshold because it would not be consisting of all pediatricians per the definition here. To expedite the prepayment review process, attach supporting documentation to the Provider Questions screen of the Pediatric Board Certification. Do you practice in multiple locations? CMS has a wonderful guide put out on the CMS EHR Incentive Program website titled Guide for Eligible Professionals Practicing in Multiple Locations. How you answer this particular question, do you practice in multiple locations, on the Provider Questions screen will impact the questions displayed on the Meaningful Use Questions screen in the General section. There is a reminder on the CMS document the Guide for Eligible Professionals Practicing in Multiple Locations, that gives you a reminder that states this is different from the requirements for establishing patient volume for the Medicaid EHR Incentive Program. You may wish to review requirements related to Medicaid patient volume since there is a variation in what is considered to be a patient encounter. So just note that the EHR reporting period, EHR reporting for the meaningful use questions, the encounter definition for that is different from the patient volume encounter. And we'll review that. Here's another attestation tip, the EHR supporting documentation. So the IME must be able to determine that you have purchased, leased, or otherwise obtained access to a certified EHR system, or have implemented and begun using or upgraded your EHR system to a certified EHR system for each year which you attest. Documentation should identify the provider or organization and the EHR vendor. To verify this, the IME will look for the business name or an address on the documentation and compare to the current case information and expect these to match with MMIS as well. If the documentation is for a hospital EHR system, and we are reviewing a clinic, we expect the documentation to support the clinic or location. We also look for a date on the documentation and expect it to be current with the required cert. Now let's take a look at the supporting documentation that can be submitted to support your EHR question screen. And it can be a combination of any of these. The items on this page, especially like item number 4 in the list here, is more for those providers who are continuing to attest past year 1 or AIU. So some examples of items that we've received and had to return the application are perhaps we received a 2011 cert supporting documentation where the required cert was a 2014 cert. So the proof of purchase contracts was for a 2011 cert, and we were in an incentive year which required the 2014 or beyond cert. So attached to the EHR questions, this will not be accepted where you had a 2011 during a 2014 requirement. So we would return that attestation. We've also received estimates or quotes to purchase a system. This is not showing us proof that you have a contract or a lease or that you've obtained the system. So this does not go along with our guidance here of these 4 bullet points. So we would again return that attestation because you have not submitted proof that you have obtained the certified electronic health record system. So a quote or an estimate is not acceptable. We have also received documentation for a different location than what is being attested to, such as a hospital location and EHR system rather than the clinic, and it was even for like a different EHR system than what was listed or had been input on the EHR questions screen, where you must include a definition of the EHR, so that again would be returned because it does not match up. We expect that the cert number and the description will be present on the supporting documentation, or the supporting documentation has resemblance to what is listed on the EHR questions page. Now let's talk about calculating patient volume. Patient volume is just one piece of the meaningful use eligibility requirements, proving the provider has enough Medicaid patient encounters to qualify for the Medicaid EHR Incentive Program. This calculation always comes from the previous year to the incentive year. So for example, for the 2016 incentive year, patient volume would come from any continuous 90-day period in 2015. This way, all claims would have adjudicated and Medicaid is able to validate the patient volume in the attestation. For purposes of the Medicaid patient volume encounter definition is services rendered on any one day to an individual enrolled in a Medicaid program. The member must be eligible for the Medicaid services performed to be counted in the numerator. An example of this would be a Medicaid member is only on the Medicaid family planning waiver and goes to the provider for an earache. This member is not eligible for the services performed, therefore this encounter would not be counted in the numerator of the patient volume calculation, but would be included in the denominator. Hawkeye encounters can only be included as a Medicaid encounter in your numerator if a provider meets the definition of practices predominantly. The IME has received questions as to what constitutes an encounter. Is Medicaid expansion included? Does Medicaid Managed Care Organizations, or MCOs, is that included? So if it fits the definition here, yes, it can be included. The definition again is services rendered on any one day to an individual enrolled in a Medicaid program. Here we see that the EPs must meet one of the following conditions, and that would be 30% Medicaid patient volume threshold. And if you're a pediatrician and meet the definition for the EHR Incentive Program of pediatrician, then you could do 20% or greater but less than 30%. Then that would be the 2/3 payment that you see here. However, if that pediatrician met the 30% or greater patient volume, then they would get the regular EP amount at $21,250 in the first year and $8,500 in subsequent years. Hawkeye cannot be included, like we talked about, unless you meet the definition of practices predominantly, and that would include the needy individuals in the numerator. Meeting the Medicaid patient volume threshold is a program eligibility requirement. An EP must meet the Medicaid patient volume to participate in the Medicaid EHR Incentive Program. So again, patient volume comes from the previous calendar year to the incentive year. For example, if a provider is attesting for 2016, you could use any 90-day reporting period from January 1st, 2015 to December 31st, 2015 for the patient volume calculation. There are two methods to calculate patient volume: the patient encounter methodology and the patient panel methodology. The IME has not seen a wide use of the patient panel methodology, so we'll focus mostly on the patient encounter methodology. Please note the definition of Medicaid encounter would be divided by the total patient encounters, where a service rendered on any one day to an individual is considered an encounter, and where services rendered on any one day to an individual enrolled in a Medicaid program is a Medicaid encounter. The IME has seen patient volume come in where multiple services are counted on one day of service for the Medicaid numerator, and in this case, we expect that the calculation was incorrect for both the numerator and the denominator. So again, you have to do services rendered on any one day. The patient volume guidebook can be found on the DHS HIT EHR webpage. We're going to go ahead and take a look at that patient volume guidebook in just a moment. As more experience has been gained with the program, it has become evident that there is a need for more guidance surrounding patient volume requirements. Therefore, Iowa Medicaid has created this patient volume guidebook to assist in streamlining the patient volume requirements, outlining specific situations where more information may be needed and when unbilled or denied encounters are used to meet the Medicaid patient volume threshold. There are several tabs across the patient volume guidebook, including instructions, definitions, patient volume worksheet, group, patient volume example of Medicaid encounters. The instructions tab also includes special scenarios. Iowa Medicaid can better expedite the prepayment audit when we have all of the information contained within this patient volume guidebook. Iowa Medicaid encourages providers to submit the patient volume guidebook as the supporting documentation, although it is not mandatory. However, the elements contained within the guidebook are needed as described. Supporting documentation needs to be clear, readable, and sortable to validate for prepayment audit. Now let's take a look at the patient volume guidebook. As you can see, there are several tabs across the bottom of the patient volume guidebook. Instructions, definitions, patient volume, group, and patient volume example. If we take a look at the instructions section at the top of the screen, there's several actions to complete, such as Step 1, Review the Definitions tab. Let's go ahead and start there. This is a reminder of what Medicaid patient volume is, and here's a reminder of what a Medicaid encounter is as it pertains to the patient volume calculation. This definition is referenced in many of the definitions below, so please note that you will see the Medicaid encounter over and over in several of the definitions below. A paid encounter is where a claim was submitted to Medicaid and Medicaid paid a penny or greater. A zero paid claim was submitted to Medicaid and Medicaid paid nothing or zero. You got a remittance advice and it showed that $0 was paid by Medicaid. So for these instances, the documentation included that you would need to include should indicate zero paid or $0 and include the Medicaid member ID and the date of service. And you'll see this requirement over and over for each type of encounter below. There's also unbilled, where a claim was never submitted by the provider to Medicaid to receive payment. Denied claims is where a provider saw a Medicaid member on a date of service and submitted a claim for the services, but Medicaid denied the claim. So again, the Medicaid member ID and the date of service at minimum would need to be provided. Global or bundled services, Medicare crossover, and if you're attesting as an individual provider or a group definition by physical location, then Iowa Medicaid does need additional documentation because Medicare drops the rendering provider or attending provider when they cross that claim over to Medicaid. That's why in those two particular situations we would need more information. Group attestation, just remember that the number 4 especially I'd like to highlight in this definition, the clinic or group practice uses the entire practice or clinic's patient volume and does not limit patient volume in any way. So please read over these 5 very carefully. Group definitions are by group NPI, physical location, and tax ID. Here's the definition of practices predominantly. And this one, if you are an FQHC or RHC, practices predominantly means an EP for whom the clinical location for over 50% of his or her total patient encounters over a period of 6 months in the most recent calendar year, which would be your incentive year, 2016, occurs at a federally qualified health center or rural health clinic. So this is a little bit different than the patient volume dates. So recall that the incentive year patient volume comes from the previous year to the incentive year. So if we're talking 2016, we're looking at 2015 for that 90-day reporting period. But practices predominantly is a little bit different because it's talking about in the most recent calendar year. So we're looking at 6 months in the most recent calendar year. If you have any questions and you're using that needy, if you're going to be using needy individuals in your patient volume calculation and you have questions on this, please don't hesitate to contact us. Here's the definition of pediatrician again, and we've had several questions about what would be included, what types of services would count for Medicaid encounters, so we've also provided this list. Now let's go back to the instructions tab. We've reviewed the definitions tab. We've already gone over where the patient volume is a continuous 90-day period in the previous calendar year. We've already gone over the Medicaid encounter definition. We do recommend that you complete the patient volume questions tab of the workbook to expedite the prepayment audit. And we also suggest that if you are only including paid Medicaid encounters and you meet the 30% or greater, go ahead and stop there with step 2, and we'll take a look at the patient volume tab here in just a moment so you can see step 2 on the patient volumes tab. And then if you don't meet the 30% or greater threshold with paid encounters, then go ahead and continue on to step 3, and that's where we're going to need additional documentation. Okay? There's special scenarios down here, so please read through those as well and see if any of those fall into your certain circumstances. Now we take a look at the patient volume worksheet. Here you enter your start date of your 90-day reporting period, and it will automatically calculate over. And I've got an example here, but I'll put in another. So it automatically updates. Then we want you to input your patient volume calculation method. In this drop-down box, you'll see individual, group NPI, group tax ID, and group physical location. Go ahead and select that. If you're testing by the individual or group NPI, please enter the NPI in the cell here. If you're testing by group tax ID or physical location, we'd like you to enter this information on the Group tab. So here you can see under physical location, then you would enter the provider names that fall underneath this definition and the NPIs of those providers. If you are attesting by tax ID, you'd select that, and then you'd enter the facility, clinic, or provider name and those NPIs. So then coming back over the patient volume tab, we'd also like you to tell us if you're a pediatrician or not. Step 1 is entering all your encounters regardless of payment status. This would be your denominator, so all encounters. Now on step 2, we'd like you to enter your paid greater than 0 Medicaid encounters. And this is all your Medicaid, whether it's primary, secondary, tertiary, etc., that you're including in that greater than 0. And then if you have received some remittance advice statements that say $0 that Medicaid paid, then you'd enter those here. And now we can see that if we were a pediatrician, we'd meet that 20% threshold. And say we didn't have any data down here just yet. Then we can see in step 2, those are our paid Medicaid encounters, and we're currently below the patient volume threshold. Now if we had met the threshold, then we scroll down here, we can see that we're at 44%, we meet the threshold, we can stop here. And you can just submit this, this page or the whole workbook, either way, and attach that as your documentation to the patient volume questions screen. Now if you needed to include, say you didn't meet the patient volume and you wanted to keep going here, we've got 16%, so we've got a whole bunch of, we've got some denied, and then we've got a bunch that we never billed. So here you can see that this boosts us up to 52% Medicaid patient volume. You can submit this along on the Patient Volume Questions tab, but because we're including these denied and unbilleds and the zero baids, we want to go over here to the patient volume example. And here we've outlined about every different kind of encounter that you could have. So some of the pieces of information that we're looking for are across the top of the screen here, such as attending, rendering, provider name. We expect to see that on your documentation. I'm a provider. The patient first and last name. At a minimum, we need to see the Medicaid ID, that's the state-issued Medicaid ID number, and this would also include the date of service. The primary Medicaid paid encounter, this could be where you received $0, or it could be where you were paid a penny or greater. Here's the example of that Medicare crossover where we would need that documentation to fit that scenario for the individual or physical location group definition. And so we just need to be able to sort by that Medicare, Medicaid, and then we would be able to figure out the number and the dates of service for those Medicaid members. Here's an example of a clearly identified denied encounter, and here's an example of a clearly identified unbilled Medicaid member receiving services on this date of service. So if you have any questions, please let us know. Once again, That's the whole patient volume guidebook. Hopefully this really helps you out. We spent a lot of time trying to put this together. All right. So continuing on, we've got the EHR and CQM reporting periods. Please note that the EHR and CQM reporting periods are different from the patient volume reporting period. I know these dates get a little bit confusing, so bear with me. Again, the patient volume always comes from the previous year to the incentive year. So 2016, you're using 2015 for your patient volume dates. But the EHR reporting period, this would be answering your meaningful use objectives and measures. And for your clinical quality measures, these dates come from the incentive year. So you're attesting for 2016. These dates should be from 2016, January 1st through December 31st, 2016 for the 2016 incentive year. 2016, we've got 90 days for all 2016 attestations for both the EHR and CQM periods. For 2017, this is where we like to mix it up a little bit, and it'll be an EHR reporting period of 90 days for all 2017 attestations. However, for the CQM reporting period, this is where we like to mix it up, 2016 again is 90 days for all 2016 attestations, and then in 2017 it would be 90 days for first-time meaningful use demonstrators. So if in 2016 you adopted, implemented, or upgraded, you did not attest to meaningful use yet, then you could go ahead in 2017 and attest for meaningful use for the first time using a 90-day period. And then it would be 365 days of CQM reporting for all other returning meaningful use demonstrators. So if you're in year 2, 3, 4, 5, or 6, you would be reporting for a full 365 days, and that's where you wouldn't be able to attest for 2017 until January 1st at the earliest, 2018. Now let's look at a great chart which captures the demonstration of meaningful use compared to the reporting periods for clinical quality measures and the EHR reporting period for meaningful use objectives and measures. Now we'll move into the meaningful use objectives and measures and discuss just how a reminder of how the program has developed over the years. Currently we're in 2016, so we are in the modified stage 2. Here's a quick run through of the goals of why the objectives and measures were consolidated. They were consolidated to remove redundant, duplicative, and topped-out objectives and measures, and consolidated into 10 objectives with 1 public health objective, so a total of 10. This chart illustrates the Medicaid meaningful use path providers must follow from stage 1 through stage 3, depending on the year they began participation. You can find this chart on the CMS EHR Incentive Program website. Now we'll review step by step each screenshot of the meaningful use questions page, as well as the measures for the 2016 incentive year. Starting off with one enhancement I'd like to note that we've implemented is the Add Document, OK, Save and Exit, and Cancel buttons are now at the top of the meaningful use question screen as well as at the bottom. So hopefully this makes it a little bit easier because the screen does refresh every time you add a document, and it goes right back to the very top of the screen. Hopefully this helps you add documents a little more easily. All providers are required to attest to a single set of objectives and measures. For EPs, there are 10 objectives, including 1 consolidated public health reporting objective, and all providers must attest to objectives and measures using EHR technology certified to the 2014 or 2015 edition. There are alternate exclusions in 2016 for those scheduled to be in stage 1 for CPOE and alternate exclusions for everyone in Stage 1 and 2 in 2016 for the public health reporting measures 2 and measure 3, the syndromic surveillance and specialized registry reporting. Oops. Here's a screenshot of the meaningful use questions page. Right at the top, we start off with entering your EHR reporting period, which could be any continuous 90-day EHR reporting period or greater. The next question is going to be where if you answer the multiple locations, practice in multiple locations on the provider questions page, this would transfer over to this second question here, and you'd be entering your numerators and denominators for each set of those locations, proving that you use the required amount of cert in those locations. Again, you might want to see the guide for eligible professionals practicing in multiple locations, and I provided that link earlier. Here we ask for the number of unique patients seen by the EP during the EHR reporting period. There's several other questions in the meaningful use objectives and measures that ask this exact same question. So what you enter here, we expect to see that throughout. So every time the same denominator question is asked, that's what we expect to see. The system also expects that. Logic was built in. So if your denominators for this particular question are not matching, the system will not let you go on. It will throw an error at you. Now let's move into Objective 1, Protect Patient Health Information. The measure is conduct or review a security risk analysis in accordance with the requirements, including addressing the security of EFI created or maintained in CERT in accordance with the requirements, and implement security updates as necessary and correct identified security deficiencies as part of the EP's risk management process. So in order to meet this objective, the provider must use capabilities and standards of CERT as defined at 495.4. You can also see I've given you some links to some really helpful resources that ONC and CMS have put together, the Security Risk Analysis Tip Sheet, and then there's also a Security Risk Assessment Guidance. So please follow those links. I've also got those posted out the DHS HIT EHR website. There's no exclusions for this measure. It is a requirement, and the provider is required to upload the Security Risk Assessment, or SRA, to the meaningful use questions and attest to doing so. Let's take a look at the PIP system. So here you can see the objective and measure. You must attest yes or no. And we also ask for a little bit of additional information, such as the date of the most recent SRA, who completed it, was an inventory list prepared, has a final report and corrective action plan been documented, and then did you attach the security risk assessment to this page? Yes or no? So in the drop-down menu, after you click Add Document, there's a drop-down menu. You can pick the security risk assessment, or SRA, and then you'd go ahead and upload your document. So a lot of times, like on the patient volume question screen, there's a drop-down list of different document naming convention. So on the meaningful use questions page, you just need to select the security risk assessment and upload your security risk assessment. I would also like to point out that CMS does put out spec sheets, eligible professional specification sheets, and that would be underneath the 2016 program year that you can find that link. Those specification sheets that CMS puts out are wonderful. It has a lot of additional information and guidance in there. It also gives you the requirements that your certified electronic health record system needs to have to meet all of these objectives and measures. So moving on to Objective 2, Clinical Decision Support, there's two measures. And in order for the EP to meet the objective, they must satisfy both of the measures. So you're implementing 5 clinical decision support interventions, and Measure 2 is the EP has enabled and implemented the functionality of the drug-to-drug and drug allergy interaction checks for the entire EHR reporting period. There is an exclusion for the second measure, any EP who writes fewer than 100 medication orders. Here's the PIP system screen. You can see both of the measures and then the exclusion. So all of those yes/no questions you need to actually answer by radio button there. If you've met the measure, you just go ahead and enter your 5 clinical decision support rules that you implemented, that the provider implemented. As a reminder, each eligible professional is attesting to meeting these objectives and measures themselves. So it's on a provider basis. If your CERT dashboard report captures the clinical decision support rules implemented information for the EP, then that will suffice as a supporting documentation. If it does not, you may need to provide other documentation such as system screenshots showing the rules implemented for the provider or providers. The IME does not want to be overburdensome, however, we must be able to validate the measure was met. So you may provide those CDS rules screenshots and include the list of providers that they apply to for whom you are attesting as supporting documentation. If you have any questions on this, please don't hesitate to contact us. Objective 3 is for computerized provider order entry, and we've got 3 measures underneath this objective. Measure 1 is 60% of your medication orders. More than 60% of your medication orders. Measure 2, more than 30% of lab orders. And measure 3 is more than 30% of radiology orders. There is an alternate exclusion for measures 2 and 3 for anyone scheduled to be in stage 1 in 2016. And this alternate exclusion would only appear for those who are actually scheduled to be in stage 1. Other providers that are not scheduled to be in stage 1 would not have this question even appear. And here's the PIP system screenshot. Again, any of the questions, yes, no, you need to answer those. And then, where applicable, enter your numerators and denominators. And then clear down here at the bottom of the objective, you'll see this, these 2 radio buttons. Sometimes folks forget these, and then you click submit that screen or OK on the screen to submit it, and it'll throw the error on the different objectives that you might have missed selecting where your data for the denominator was extracted from. And there are several questions throughout the Meaningful Use question screen where this is applicable. Objective 4 is electronic prescribing. More than 50% of permissible prescriptions written by the EP are queried for a drug formulary and transmitted electronically using CERT, and there are an exclusion any EP who writes fewer than 100 permissible prescriptions during the EHR reporting period or does not have a pharmacy within his or her organization, and there are no pharmacies that accept electronic prescriptions within 10 miles. And here's the screenshot from the Meaningful Use Questions page, showing you the objective and the measures. Does the exclusion apply to you? Yes or no. Enter your numerator, denominator. The percentages always calculate automatically after you enter your numerators and denominators. And again, here's the extracted from radio buttons. Objective 5 is health information exchange. The measure is the EP that transitions or refers their patient to another setting of care or provider of care. Use CERT to create a summary of care record and electronically transmit such summary to a receiving provider for more than 10% of transitions of care and referrals. The exclusion on this measure is any EP who transfers a patient to another setting or refers a patient to another provider less than 100 times during the EHR reporting period. The EP must select the applicable radio button once again for how the denominator data was extracted, as you can see here. So again, you need to answer all of the questions, yes or no, enter your numerator, denominator, it'll calculate your percentage automatically, and then right over here, make sure you select your radio button. Patient-specific education. The measure is the EP that transitions or refers, oops, sorry, that's not it. The patient-specific education resources identified by CERT are provided to patients for more than 10% of all unique patients with office visits seen by the EP during the EHR reporting period, and the exclusion is any EP who has no office visits during the EHR reporting period. Here the numerator is the number of patients in the denominator who were provided patient-specific education resources identified by the CERT, and the denominator is the number of unique patients with office visits seen by the EP during the EHR reporting period. Objective 7, the measure is the EP performs the medication reconciliation for more than 50% of transitions of care in which the patient is transitioned into the care of the EP. There is an exclusion, any EP who was not the recipient of any transitions of care during the EHR reporting period. The numerator is the number of transitions of care in the denominator where medication reconciliation was performed, and the denominator is the number of transitions of care during the EHR reporting period for which the EP was the receiving party of the transition. Once again, you'll see that you need to enter where the denominator data was extracted from, so select your radio button, and otherwise answer the questions and enter your numerators and denominators. Objective 8 is patient electronic access, where EPs must satisfy both measures in order to meet this objective. Measure 1 is more than 50% of all unique patients seen by the EP during the EHR reporting period are provided timely access to view online, download, and transmit to a third party their health information subject to the EP's discretion to withhold certain information. Measure 2 is, for an EHR reporting period in 2016, at least one patient seen by the EP during the EHR reporting period or patient authorized representative views, downloads, or transmits his or her health information to a third party during the EHR reporting period. There is an exclusion. For measures 1 and 2, any EP neither orders nor creates any of the information listed for inclusion as part of the measures except for the patient name and provider's name and office contact information. For measure 2, any EP who conducts 50% or more of their patient encounters in a county that does not have 50% of or more of its housing units with 4 megabits per second broadband availability according to the latest information available from the FCC on the first day of the EHR reporting period. I've included a link here to the broadband access exclusions tip sheet, and this does Exclusion 2 does not apply to Iowa providers, as there are no counties listed here that Exclusion 2 would apply for. So take a look at the broadband access exclusion tip sheet, and that will lay it out for you. Objective 8, in the PIP system, as you can see, there's kind of a breakout of the exclusion section with the numerators and denominators. Here you're going to see that where Iowa Medicaid expects when the denominator is the number of unique patients seen by the EP during the EHR reporting period should match what was entered in the general questions section. The denominator should not change when the same question is asked. Objective 9 is secure messaging. For an EHR reporting period in 2016, for at least one patient seen by the EP during the EHR reporting period, a secure message was sent using the electronic messaging function of CERT to the patient or the patient authorized representative, or in response to a secure message sent by the patient or the patient authorized representative during the EHR reporting period. An exclusion 1 has no office visits during the EHR reporting period, or any EP who conducts 50% or more of her. And again, this exclusion 2 does not apply to anyone in Iowa. Here's what the PIP system looks like for Objective 9, secure messaging. Again, you're going to need to answer the yes/no questions and enter your numerator and denominator. And once again, this question also asks the number of unique patients seen by the EP during the EHR reporting period, and we would expect the same denominator result throughout where this question is asked. Next, let's take a look at the public health reporting. In order to meet the objective, the EP must choose a minimum of 2 measures from measures 1 through 3. The EP may attest to measure 3 more than one time to satisfy this requirement. Any provider that cannot meet the minimum threshold of 2 measures must qualify for an exclusion to all the remaining measures. These measures may be met by any combination in accordance with applicable law and practice. And so there's 3 measures: the immunization registry, syndromic surveillance, and specialized registries. So we'll take a look at some helpful guidance and then the PIP screens for each of these measures. Here are some helpful links regarding the public health measures. I've included here the Iowa Department of Public Health Readiness, Iowa Department of Public Health Meaningful Use Letter, and then a link to the Eligible Professionals Public Health Reporting in 2016. This will link you out to the CMS EHR Incentive document, and this document gives you references to several CMS FAQs pertaining to the public health reporting. There are alternate exclusions in 2016 for measures 2 and 3, and there was some additional guidance put out by CMS in FAQs 14397 and 13653 for the claiming an alternate exclusion in 2016 and specialized registry. On these 3 different measures, you also have to, if you attest to meeting the measures, you'd have to respond with your level of active engagement. Active engagement is defined for all 3 measures as 1. Completed registration to submit data, where the EP is registered to submit data. Registration was completed within 60 days after the start of the EHR reporting period, and the provider is awaiting an invitation to begin testing and validation. Level 2 would be testing and validation. The EP is in the process of testing and validation of the electronic submission of data. Providers must respond to requests from the sponsor of the registry within 30 days. Failure to respond twice within an EHR reporting period would result in the EP not meeting the measure. And production. EP has completed testing and validation of the electronic submission and is electronically submitting production data. So objective 10, measure 1. Just a reminder that meaningful use is on a provider basis, so the provider is attesting to have administered immunizations and submitting the data to the immunization registry. If you take a look at the link on slide 59 for eligible professionals public health reporting in 2016, this document has several FAQ links within it that may assist you in understanding how to attest. The EP must answer yes or no to all of the exclusions whether you met the measure or not, and then attest to the level of active engagement. Again, on measure 2, the EP must answer yes or no to the exclusions and meeting the measure, and where the EP meets the measure, the EP must choose the best description again of the level of active engagement. The Iowa Department of Public Health has not declared readiness. However, there are some county health departments in Iowa who have declared readiness for this measure. For measure 3, this is the specialized registry reporting. The EP must answer yes or no to the exclusions and meeting the measure, and where the EP meets the measure, the EP must choose the best description of active engagement. Also, for these measures, for measure 3, we ask that you input the name of the specialized registry where you're reporting the data. Now note that the IME must be able to validate what you have entered in the specialized registry text box with your supporting documentation. So we advise that the documentation and the text box description match for ease of the review of the documentation. So for example, if you attest to the cancer registry and your supporting documentation says cancer registry, but here on the PIP screen in the text box you entered System 2017, we would not be able to easily validate that measure was met. This may result in a return to application and prolong the review process. And then CMS gave some guidance Step 1, check with the state registries that are available, and Step 2, check with specialty societies with which you are affiliated and see if they have an endorsed registry, and document your own circumstances. So that concludes the meaningful use questions section. Now we'll just talk briefly about post-payment audits. The IME will randomly select folks that have received an incentive payment for a post-payment audit. And providers must retain all of their supporting documentation as proof of each attestation of no less than 6 years after each payment year. Informational letter 1742 was sent out and posted November 7, 2016, which notified providers and hospitals that the IME has contracted with Myers & Stauffer LC to perform post-payment audits for the EHR Incentive Program. Providers who have been randomly selected for post-payment audit will be contacted by Myers & Stauffer LC, who are based in offices outside of the state of Iowa. If a provider is selected for a post-payment audit, they will have 30 days to respond and provide documentation so Myers & Stauffer LC can complete the review of the post-payment audit. And we've just listed some examples here of items that you would want to think to keep on hand for no less than the 6 years. Now let's talk about avoiding the Medicare payment penalty and the alternate attestation method. Here's some resources that you want to take a look at. The Payment Adjustment and Hardship link will take you out to the CMS EHR Incentive Program website, and within that website there's also a really nice document titled 2017 Medicare Electronic Health Record Incentive Program Payment Adjustment Fact Sheet for Eligible Professionals, and it does give a really nice summary. So if you are subject to the Medicare payment adjustment, I do suggest that you take a look at that document. In the American Recovery and Investment Act of 2009, ARA, Congress mandated that payment adjustments should be applied to Medicare-eligible professionals, eligible hospitals, and critical access hospitals that are not meaningful users of certified electronic health record technology under the Medicare EHR Incentive Program. If a provider is eligible to participate in the Medicare EHR Incentive Program, they must demonstrate meaningful use in either the Medicare EHR Incentive Program or in the Medicaid EHR Incentive Program to avoid payment adjustment. Medicaid providers who are only eligible to participate in the Medicaid EHR Incentive Program are not subject to these payment adjustments. The table illustrates the timeline to avoid payment adjustments for eligible professionals who demonstrated meaningful use. The EHR reporting periods for the payment adjustments will begin and end prior to the year of the payment adjustment. Eligible professionals must continue to demonstrate meaningful use every year to avoid payment adjustments in subsequent years. A provider may not use the alternate attestation option to attest to meaningful use in Medicare to avoid a payment adjustment in conjunction with an attestation for an incentive payment for AIU in the Medicaid program in the same year. Medicaid EPs seeking to exercise this option must attest in the Medicare system and in accordance with the requirements for the Medicare EHR Incentive Program in order to successfully demonstrate meaningful use and avoid the Medicare payment adjustment. For an EP who uses this alternate method, their EHR reporting period in a subsequent year for the Medicaid EHR Incentive Program would be determined without regard to any previous attestations using this alternate method. Medicaid EPs who do not meet the eligibility criteria to attest to the Medicaid EHR Incentive Program and want to avoid Medicare payment adjustment would have the option of attesting through the EHR Incentive Program Registration and Attestation System for the purposes of avoiding the Medicare payment adjustment. This alternate method would allow EPs who have previously received an incentive payment under the Medicaid EHR Incentive Program for either Adopt, Implement, Upgrade, AIU, or Meaningful Use to demonstrate that they are meaningful EHR users in situations where they fail to meet the eligibility criteria for the Medicaid EHR Incentive Program in a subsequent year. So here you can attest with the Medicare registration and attestation site to avoid the payment adjustment. An example of how this would not impact the EP, they would if you needed to avoid that Medicare payment adjustment, but you didn't qualify for the Medicaid incentive for that particular incentive year, you can attest out of the Medicare registration and attestation site, and then that doesn't impact your incentive program year for, say, like if you AIU'd in 2015 and then in 2016 you didn't meet the Medicaid patient volume, so you were still a meaningful user, you met all the meaningful use requirements, you just couldn't meet the eligibility requirement to participate in the Medicaid incentive program for that incentive year, then you could go out to the Medicare registration and attestation site and attest there. In doing so, you would not lose your 90-day EHR reporting period for the Medicaid EHR Incentive Program for the first year that you attested with the Medicaid EHR Incentive Program for meaningful use. The EP must meet all of the Medicaid eligibility requirements and pass the prepayment audit for Medicaid to report the successful meaningful use attestation to Medicare. So later, if there are findings, say in a post-payment audit for the payment year on a post-payment audit, which determines the EP did not meet meaningful use, the state will also report this to CMS as well. Now let's take a look at some changes ahead for the 2017 program year. We've already talked about how adopt, implement, upgrade, or to initiate participation in the Medicaid EHR Incentive Program. Your last chance was 2016 incentive year, and right now we're talking about the 2017 program year. So just to reiterate, in 2017 program year, no new entrants to the program are allowed. So if you want to attest for the 2016 incentive year, you may do so through March 31st, 2017. Meaningful use, year one, we talked about how that's 90-day reporting. And for those folks, it would begin April 1st, 2017 through the 2017 tail period, which is yet to be determined, and a 90-day reporting for EHR and CQMs for both, for the meaningful use year one attestations in 2017. For meaningful use year two and beyond, for 2017, you would have a 90-day EHR reporting period or greater, and clinical quality measures would be a full calendar year reporting. So you would have to wait for 2017 calendar year to end, and then you can begin testing in January 2018 through the 2017 tail period, which again is yet to be determined. There are a few EHR questions page updates that you should expect for the 2017 attestation timeframe. So the final rule updates the definition of meaningful use to include supporting healthcare providers with the performance of certified EHR technology, or SPPC. To engage in activities related to supporting providers with the performance of CERT, you must attest that I acknowledge the requirement to cooperate in good faith with ONC direct review of CERT, and if requested, I will permit timely access to such technology and demonstrate its capabilities as implemented and used in the field. Optionally, you may attest that you acknowledge the option to cooperate in good faith with ONC ACB surveillance of CERT, and if requested, you would permit timely access to such technology and demonstrate its capabilities as implemented and used in the field. The final rule also updates the definition of meaningful use to include support for health information exchange and the prevention of information blocking. For the EHR reporting period, you must attest to the following. You did not knowingly or willfully take action to limit or restrict the compatibility or interoperability of the CERT. The CERT at all relevant times was connected in accordance with applicable law, compliant with all standards applicable to the exchange of information, allowed for timely access by patients to their electronic health information, and allowed for timely, secure, and trusted bidirectional exchange of structured electronic health information with other healthcare providers and other CERT technology and vendors. And thirdly, you responded in good faith and in a timely manner to requests to retrieve or exchange electronic health information. Here's what those items will be added to the EHR questions page as questions 3 and 4. Again, you must attest to 3A to meet this requirement. You may optionally attest to 3B, and for question 4, you must attest yes to meet the requirements of the EHR Incentive Program for 2017 and beyond. The EHR questions page will also be updated to include options for 2017 where a provider attests with 2015 CERT or a hybrid of 2014 and 2015 versions of CERT. The provider will be presented with the option to attest to modified Stage 2 or to Stage 3. Once the selection is made, the Meaningful Use question screen will display the objectives and measures selected on the EHR questions page. If later the provider wishes to change the stage to which they want to attest, the provider would return here to the EHR questions page and modify the selection. A warning message will display as follows. If you changed the stage to which you are attesting, then you would see this message here. This will clear the data entered on the Meaningful Use questions page and change to the objectives and measures corresponding to the stage selected on the EHR questions page. Again, here's the Medicaid participation timeline. Just to recap some dates. For Medicaid providers who are demonstrating they are meaningful EHR users for the first time in their second payment year, the EHR reporting period during such second payment year is any continuous 90-day period within the calendar year, and all returning meaningful users, you have to report the full year of CQMs as we already discussed. And in 2017, you also get to choose whether you'd like to attest to Stage 2 or Stage 3, depending on that 2015 CERT or the hybrid model. You would not be presented with those questions if you didn't meet the 2015 or the hybrid. And then in 2018, at least as it stands now, first year meaningful use, you do a 90-day reporting period, and all other returning meaningful user reporters would be a full year for both the EHR and CQM reporting. And in 2018, everyone will be attesting to Stage 3 objectives and measures, and in 2018, you would have to use a 2015 CERT. Sources I've discussed throughout the presentation, CMS EHR Incentive Program website, here's the link, and the DHS HIT EHR website. If you have any questions, please don't hesitate to contact us at imeincentives@dhs.state.ia.us. If you have any questions, please don't hesitate to contact us. I appreciate your time, and hopefully this is helpful information as you proceed with your 2016 attestations. Thank you.